So my name is Michael Frakes. I'm the Director of Clinical Care at Boston MedFlight, and I'm going to talk clinically here in a minute. First, I want to thank everybody for coming to this meeting. I'm always impressed when we get a bunch of people to put time in on their days, nights, weekends off, whatever, to learn things about patient care. So I appreciate that everybody did that. We should recognize Sam and Matt for the excellent job that they did putting this program together. And looking at the brochure, which I assume that everybody here did, this is an amazing panel of speakers, except for this talk that's about to happen. But it's a great show. And it's made even better by the fact that, to my knowledge at least, the speakers are all volunteers. So it's really impressively put together. The way this whole thing comes together also is a good representation of Boston MedFlight, the work that we do here. Our business is collaboration. And so you can see that our partner hospitals are working very closely with us to help this come together. So we're doing shows here at the Beth Israel and across the street at the Brigham and Women's, which are two of the premier medical centers in the country. They've donated a bunch of time and logistic support to us. And our other partner hospitals are contributing as well in terms of other methods of support. And you're going to see some of their people here doing talks. So again, so I appreciate that everybody came here to help make this happen. And so I will do my best to meet your needs and your high expectations here, because you're giving your time up for this. So I don't have quite 30 minutes to do this. I have about exactly as much time as you get for a primetime TV sitcom. And in that amount of time, I'm going to try to present you information about high-performance critical care. So really, what could possibly go wrong with that, right? But it's important information, because what we're going to talk about is how to take care of a group of patients who are very ill and require our very best. The gentleman before me made a very clear and important point that we're not building cabinets. When I went through training, they told us we weren't flipping burgers. This is important work that we have to be really good at every time. So let's get started. So my disclosure slide is I don't have anything disclosed. I'm counting this as work time. I will disclose that Boston MedFlight's looking for nurses and paramedics, so if you're interested, come in and see me after the show today or after the show tomorrow. And I'm going to tell you that, like any good speaker, I stole images off the internet, fair and square. I don't endorse anything. Right? I just use the pictures because they work in the show. So what we're going to do in the next couple of minutes without commercial breaks is I'm going to give you some quick tips talking about patients with poisoning. I'm going to give you fun trivia, because I want you to be able to go back to your programs and be able to win bets from your colleagues, as well as being able to take better care of patients. Then we're going to talk about the management of critically ill patients and the way to help improve their outcomes. And finally, I'll give you some stuff that sort of is from the evidence-free zone, so that you can pick around the medical director and try to make them do stuff that they don't want to. So this is an important group of patients. Thinking about patients with poisoning, this is very important. Poisoning is the #2 cause of unintentional death from unintentional injury in adult patients, and it's the #2 cause of ED visits for an intentional injury. So we see a fair number of patients in there. And the first quick fact I'm going to tell you about toxicology didn't make this slide. It's the fact that patients with poisoning almost always do really well in spite of what we do. Okay, so toxicology is extraordinarily complex, but the overwhelming amount of medicine for that is just good supportive care. And everybody in here is great at supportive care. All right? You didn't come here to talk about good supportive care. What we're going to talk about is the patients who are a little bit... Do my microphone start? Okay. Right at the same time you together. All right, well, the same comes back. We'll ask them to... We'll see how it goes. All right. So we're going to talk about the patients who don't require just supportive care. We're going to talk about the patients where our care really makes a difference. So much like this microphone does not make a difference. Are you able to hear from the back if I just talk loud? All right. That's never been a problem my entire life. So patients who actually make a difference. So there's a group of toxicology patients where specialized interventions and really aggressive care will make the difference between live and die, will make the difference in that outcome. And that's the business that we bring in critical care. So we're going to talk about those patients. The first thing we have to do with patients who are poisoned is know that they're poisoned. And that's not always really obvious, right? Sometimes they pass out and the pill bottle's still in their hand and we can figure it out. Sometimes it rolls under the couch and then it's not as obvious. And so we have to think that patients have poisoning more times than patients do, so that we don't miss the patients who need our interventions. And so anytime you have a patient who's a little bit of a fascinoma, put toxicology on the differential, right? Because who here is in their first week of working taking care of sick people? Almost nobody at this meeting, right? So you know what sick people look like. You know the patterns of sick people. You can figure out what's up with most patients. And as soon as you're like, man, this is weird, put toxicology on the differential. And it may or may not be there, but it may clue you in that somebody needs one of the interventions that will make the difference in a patient who has a poisoning. So be a curious medical detective is the description someone once told me. Thinking about patients with poisoning also, always think simple stuff. Aspirin and Tylenol. Okay, so 50% of patients who die from aspirin overdose come in with a GCS of 15. So with a shout out to Linworth Jacobs, who's one of the pioneers of trauma care and helicopter emergency medicine, if you come in talking, you should leave walking. And so if 50% of the patients who die from aspirin overdose come in talking and leave dead, you're missing something. So anytime you're thinking toxicology, be sure to check for aspirin overdose. Same thing, up to 11% of suicidal patients have a measurable Tylenol overdose. 1 in 300 has a Tylenol level greater than 50. That's a magic number. That's a big deal. Okay, so don't miss something that is so incredibly simple, so incredibly common, and so easy to screen for. A lot of times in the course of managing patients with poisoning, we want to do single-dose activated charcoal, and we want to do gastric lavage, and there's not much use for that unless you're physically present when the patient takes the poison. All right, there are some rare exceptions, especially if things where almost nothing else will make you better. But the overwhelming recommendation from the toxicologist is that there's very limited role for single-dose activated charcoal and for gastric lavage. So by the time we get there, it's almost never worth adding that to the picture. So now let's move into fun trivia. So what's the most common poisoning that we see in emergency medicine 911? Right, it's the opiate overdose, right? So you guys, I think the Course Hotel and maybe the Course social event tonight are in Southie or something like that. So you're going to see an opiate overdose tonight. And so you didn't come here to learn that Narcan fixes those, right? So it's the most commonly used reversal agent for patients with poisoning. The question is, what else does Narcan fix? Okay, so here you have to guess them also in the order that I'm going to do them. So my people in the front here say clonidine, right? A central acting anti-adrenergic agent that we see in patients who are trying to get off the juice. Well, they're not great decision makers all the time anyway, so we see clonidine overdoses. We also see a lot of unintentional clonidine overdoses when their children eat the pills. Okay? But remember that Narcan may help reverse the respiratory depression of a patient with a clonidine overdose. So that'll help you out, right? What else does naloxone reverse? So you're going to win tons of free beers when you go back home. Dextromethorphan, what's that? Yeah, that's cough syrup. Okay? So again, some intentional overdoses of cough syrup, a lot of unintentional overdoses for cough syrup. So now we're coming up with a whole list of ways that we can wake up children who have unintended poisonings and respiratory depression by using Narcan. So it works very well to reverse respiratory depression with dextromethorphan as well. Valproic acid, is that a medicine you're familiar with? Yeah, that's an anticonvulsant, right? And so, again, both intention, hardly anybody tries to kill themselves with valproic acid. Right? I'm sure that sometimes it comes up when you eat everything that's in the pill safe, but unintended overdoses of valproic acid, one of the signature features of that is CNS depression, and the Narcan may help reverse the CNS depression from a valproic acid overdose as well. The last thing it'll reverse is a loperamide overdose. What's loperamide? Yeah, so it's curious to me that everybody in the room knows that, but yeah, loperamide is Imodium, right? Okay, so I don't want to know how you know that, but so who knew that Imodium was a drug of abuse? A couple people will ask you why you know that later on as well. Because the way that loperamide works is it's a very low dose opiate that normally only works in your GI system. And remember, now there's a whole new medicine for opiate-induced constipation. So it will be a great anti-diarrheal, right? But it turns out if you can't get anything else, there's now a recreational market for Imodium. Such a market, in fact, that the New York Times has made it a story, so it has to be right. It turns out that naloxone will also reverse the respiratory depression associated with loperamide. So, not just for heroin ingestions anymore. So that's some fun trivia. They can wake up some patients who you need to wake up. We're going to move on and talk about more serious things now. We're going to talk about cardiotoxic overdoses. And so individually, this is the seventh most common poisoning, the fifth most common cause of death, so it's kind of a big deal. And it harkens back to somebody that everybody liked to see when you were in training, so everybody loves the action potential, right? Raise your hand if you love the action potential. Fred actually wants to raise his hand. So everybody loves the action potential. The reason the cardiotoxic poisonings are important and the reason they are deadly is because they mess this up. Okay? And so you can guess that that's going to make you not thrive very well. The classic cardiotoxic poisoning is the tricyclic antidepressant poisoning. Right? So everybody knows that. The tricyclic antidepressants are mostly used for depression, okay? So also used for chronic pain and for attention deficit hyperactivity disorder. So they're very much out there in the business. The bad news about them being great antidepressants is you give them to people who are depressed, and it's very easy to kill yourself with them. So sometimes we see intentional overdoses from these. But since they're out there in people with chronic pain, people with attention deficit hyperactivity disorder, and whatever else, we also see a lot of unintentional overdoses. The thing that we want to remember about the tricyclic antidepressants is that it's not just a TCA overdose we're looking at, it's a class of drugs overdose. And that's the sodium channel blocking drugs overdose. Okay? And one of the themes of my life is I'm always mad that somebody didn't tell me something a long time ago, because if they had, it would have made the rest of my life easier. This is one of those things, because I learned a lot in paramedics training about tricyclic antidepressant overdoses. But nobody ever pointed out that it was the sodium channel poisoning that was killing people. And had they, it would have made my life a lot easier, because what other medicines poison your sodium channel? Okay, lidocaine, yep, so all of the class 1 antiarrhythmics do, but the list is huge, all right? It's so huge, you may be able to read from back there. But so obviously it includes all the class 1 antiarrhythmics, right? But also a bunch of other stuff you've seen. 1A, 1C antiarrhythmics, it includes Celexa down there at the bottom, diphenhydramine up there. It includes the beta blockers, are also sodium channel blockers. The calcium channel blockers are also sodium channel blockers. So there are a bunch of other medications which are sodium channel blockers. So it's not just the management of the TCA overdose that we're thinking about here. It's the management of the patient with sodium channel blocker poisoning. And that's vastly more common than we thought it was. It also includes down here at the bottom cocaine. All right, we see a modest number of people who take just a little too much cocaine and get in trouble. It's a sodium channel blocker in addition to all the other things, right? So as we get back into the conduction system here, we put that up again, and this starts talking about where the various von Williams classes of antiarrhythmics work on the action potential. So if you're super sciencey, you think about antiarrhythmics in the von Williams classes and you lay it over on the action potential. But what you really need to know is that the different classes of drugs work in different parts of that action potential, but they still all impair cardiac conduction. Okay, if we lay that over on top of the QRS complex, that tells us where we're getting in trouble. So if we have sodium channel blocker problem, you can say that's going to be a phase 0 problem. It's going to be a QRS duration. So we're going to start to see changes in the QRS complex. All right, that's going to clue us in. So, and everybody learned this in your training. You learned it for TCA overdoses, but it's for every sodium channel blocker poisoning. And you learned that first the QRS widens out, and then it widens out into a sine wave, and then you have ventricular fibrillation, and then you have the death, right? Did everybody hear that once in your training? So we all kind of know that. But we didn't tell you everything. All right? Stuff you wish they told you earlier. So in addition to the widening of the QRS, what other EKG finding is pathognomonic for sodium channel blocker poisoning? I'm all about work right now, because you got to talk really loud if you can answer questions. Right? So what else is it? It's circled up there. Okay, it's super easy to slide. So a terminal R wave can lead AVR. So what we're talking is we think about EKG changes and why that's important. a QRS duration greater than 100, third of those people will seize, 1 in 7 will have a ventricular arrhythmia. So that's why we always care about the conduction intervals on patients who have poisoning. As soon as the QRS duration is too wide, that patient's in trouble. We need to do something about that. QRS widens out to 160, there's a 50% chance they're going to have ventricular arrhythmia. And then we start talking about the next problem we get, or the next EKG finding, which is a terminal R wave greater than 3 millimeters in lead AVR. All right, if you can only remember very short things or things that rhyme, which is how I work, it's R3R. An R wave greater than 3 millimeters in lead AVR. And that's 81% sensitive and 73% specific for the development of seizures and arrhythmias. Remember that specific is positive. Specific rules in. So if you have that terminal R wave, very high likelihood that you can have seizures and arrhythmias. Okay, so the two findings we're interested in, not just for TCA overdoses, but for patients with sodium channel blocker poisoning, are QRS duration widening greater than 100 and terminal R wave in lead AVR. So what do we do for those patients? We give them the bicarb, right? Everybody knows that. That was basic paramedic training. Everybody knows that. And we usually say we give them 1 to 3 milligrams per kilogram or something like that. And it works. Okay, so live action EKGs from a patient who's known to have a tricyclic antidepressant poisoning. And you can see the QRS is 142, and you can see a giant R wave in lead AVR. Everybody's good with that? Okay, so rightward axis as well. And then, look what happened. So we give them some sodium bicarb, the QRS duration comes down to about 99, and you can see that the terminal R wave starts to decline, and then very shortly thereafter, just from the administration of sodium bicarbonate and no other magic elixir, the QRS duration is normalized, and the terminal R wave is gone. Okay, so it works. It works like $1 million. The bicarb works in these patients with the same sort of amazingness that weighed-in diabetics up with E50 does, which was the greatest thing you could do as a paramedic. So what we know is that the sort of the stated dose is 1 to 3 milliequivalents per kilogram, but really what we do is we give the bicarb until the QRS duration is under 100. Okay, so the dose is as much as you need to get the QRS duration to come down, because that's associated with adverse outcomes. But here's the question. Remember, the genius is the person who can answer why 3 times. So I'm just going to ask it once. Why did the bicarb work? Yeah, so somebody here says that it does something, but increases the pH. And part of the classic teaching is that that's super helpful, right? You give enough bicarb to keep the pH greater than 7.5, and there may be a pH-dependent effect because it changes how the drug is offloaded. But what is really the magic part of the sodium bicarbonate in the patient who has sodium channel blocker poisoning?
Sodium.
It's the sodium. Again, why didn't you tell me that 30 years ago, right? So the reason that we're using the sodium bicarbonate, there may be some benefit from the pH, but really it's because we're given enough sodium. Okay, so sodium bicarbonate, again, in the preload has 1,000 milliequivalents of sodium in a liter. And so that's a lot. That's twice as much as you get in 3% saline. It's almost as much as you get in 7.5% hypertonic saline. So we're using the bicarb because it comes in an easy, convenient to access box that has a ton of sodium. And so we're just giving the sodium to make those patients worse. It does alkalinize the patient, so remember that alkalinization moves potassium, and since it changes the pH, you're going to need to be able to blow off the CO2, so pay attention to ventilation as you're doing that. But so the easy answer for patients with sodium channel blocker poisoning, and remember it's this giant list of drugs, not just a couple. So patients who have any reason to think they're poisoned and a QRS duration greater than 100 and an R3R is to give those patients enough sodium in some form that their QRS duration is. Most of the sodium channel blocking drugs also have anticholinergic effects. And so who knows the anticholinergic toxic drug? This is my favorite toxic drug of all time. Go ahead. I love this one, right? So, red as a beet, dry as a bone, blind as a bat, mad as a hatter, hot as a hare, fast as a fox. Okay, it's the only toxidrome that it includes nature in it, so it's good. But what that means for us as curious medical detectives is that if you have sodium channel blocking systems and bradycardia, because you're supposed to be fast as a fox, means that something else is going on. It's either a different agent or there's a co-ingestion. Right? So our business is about recognizing patterns. If we see a pattern, we treat the pattern. If we see a pattern developing, we treat the pattern early. But if we see something that doesn't match the pattern, we have to explain why that is. We have to solve the unresolved discrepancy. Next group of cardiac toxicities I'm going to talk about is blocker toxicity. So I'm going to talk about calcium channel blockers and beta blockers. And we always think of them as separate drugs. Bring them together. Okay? Let the calcium channel blockers be with the beta blockers if they want to be together. And in my simple world, you can treat those overdoses the same, and you're not going to get into any trouble, and you're going to have better outcomes, and your brain's not going to hurt as much. All right, so we're just going to talk about blocker toxicity for those patients. Again, working in the cardiac conduction system, so you see the beta blockers there on the right, and then the calcium channel blockers all the way up there at the top throughout much of the cardiac conduction system. Okay? And you know that for both beta and calcium channel blocker toxicity, you get bradycardia hypotension. That's not super hard. The drugs do behave a little bit different with greater mental status change and greater respiratory depression with beta blocker toxicity, hyperglycemia with severe calcium channel blocker toxicity, and there's some calcium channel effect that varies by class of drugs. All right, so the dihydropyridines are more vascular, the non-dihydropyridines have more cardiac activity. And so if you know what the drug is, you can help tailor your treatment a little bit, or if you're looking at this bunch of vital signs, you can help maybe think of what kind of agent it is, right? But the short answer is they're still all calcium channel blockers or beta blockers, and we're going to manage patients who have blocker toxicity. And when I used to talk about this, it was really easy to do because there's actually no guidance. As late as 2014, the end of 2014, the World Group of Toxicologists, a very smart bunch of guys, said there was no good guidance on what to do for these patients. So I could stand up here and make up anything I wanted, and if I talked fast enough, I could get away with it. That is no longer true. So you come to the ECHO meeting because you want current information. The current information is that earlier this year, there's a consensus guideline for how to manage calcium channel blocker poisoning. So now you're no longer guessing. Now there's a standard of care. So this is what you're supposed to do. Okay, so I could be up here telling you that what you have been doing until today is not right. There's a consensus guideline on what you're supposed to do, and I'm going to say that it will work just fine for both calcium channel and beta blocker poisoning. So here's what it is. But rather than just have you read that for a while, which would be an awesome talk, I'm going to say that you'll never guess what you do for patients who have bradycardia. ACLS, okay? Medicine's usually pretty easy. It's always okay to do advanced cardiac life support if indicated. 20% likelihood that atropine will be effective in these patients. Pacing may be effective. Remember, you're poisoning the conduction system. With pacing, you're capturing conduction system, so it may or may not work, but it's worth a shot. So start with good basic ACLS for people who look like they have bradycardia and hypotension. As you work through the bradycardia algorithm, it talks about using a catecholamine infusion. Dopamine may or may not work, but an epi infusion will work really well for these patients. Okay, so 2/3 likelihood that epi will be effective, especially in improving heart rate in these patients. And so if atropine doesn't work, or you don't feel like trying it, pacing doesn't work, you're not game for that, an epi infusion in somebody who has calcium channel blocker poisoning or beta blocker poisoning is a great idea, and it may work really well for you. Okay? Norepinephrine, as well as epinephrine, will support the blood pressure. Okay? So if the problem is more hypotension than rate, you may think norepinephrine. Epinephrine will definitely improve blood pressure and will improve contractility. Right? So probably the take-home point from that is the dopamine is not super duper helpful for these patients. Norepinephrine probably is, and epinephrine is a great idea if you have to bring up heart rate and blood pressure in patients who have calcium channel beta blocker toxicity. So one of the things you're supposed to do when you try to teach people things is make them talk about it over and over until they remember, right? So what if we decide makes your life better if you have a sodium channel blocker poisoning? Sodium, okay, so you have great retention. What do you think will make your life better if you have a calcium channel blocker? Calcium, okay? See, medicine's easy. So it's a great idea. If somebody has a calcium channel blocker poisoning, give them some calcium. If they have a beta blocker poisoning, give them some calcium as well. Okay, it may be effective. In both patients, probably will improve blood pressure more, or a cardiac output more than heart rate, but may be effective in supporting their blood pressure. It's positive isotrope. Think about how you're giving it. Okay, remember that calcium chloride has 3 times as much free calcium as gluconate does, and so it's easier to cause vascular problems and all that kind of stuff. But it doesn't always work. Okay? It certainly is worth a try for both those patients, both those groups of patients. Who has ever been told that if you give calcium intravenously to a patient who has dig toxicity, they will die right then? Everybody, so I don't know if this is an old school thing or if it's always just few people that remember, but sort of classically they say, well, turn your heart to stone, right? That doesn't happen. All right? So our good friends at Banner Good Samaritan Medical Center in Phoenix, one of the premier medical centers in the country, looked at patients who had digitalis toxicity and got some calcium intravenously because nobody knew that they had dig toxicity. And they looked at a long case series, and you know how many of those patients died? None. All right, so it is totally safe. And so that concern for calcium was probably not true. Then again, remember, so we're talking about beta blocker and calcium channel blocker poisonings. Remember that they also have sodium channel blocking properties. So with these patients, as you start to resuscitate them, so we've done basic ACLS, we've done latropine, we've thought about pacing, we've started norepi infusion, we've started epi infusion, we've given a little calcium, and they're still not responding. Think about the possibility that there's also sodium channel blocker poisoning and see if they're responsive to sodium bicarbonate. Okay, so remember, it's sort of a co-ingestion, so they may be responsive to sodium bicarbonate. Another first-line treatment for these patients is insulin. So who's using insulin for treatment of patients with cardiotoxic ingestion sparing? That's a clue. Everybody from Boston Med, raise your hand. So not only is it a reasonable idea, it's a first-line treatment. Okay? So here's what you need to do. Insulin by itself is a positive inotrope. It increases cyclic AMP production and may enhance catecholamine release. And so really what it does is it makes your cardiac conduction work through the back door. So if there's adrenergic blockade, calcium channel blockade up front, this is a backdoor way to make it work. Okay, so improve carbohydrate metabolism and glucose utilization that powers cardiac myocytes. Here's what makes it work, or here's how you're going to make it work. You're going to give these patients a unit per kilogram of insulin as a bolus. All right? What's going to be happening to you while you do that? Yeah, 2 things. Your hand's going to be shaking because that's more, especially if you were ever a nurse in the hospital, right, where insulin is like radiation. So your hand's going to be shaking because giving me 70 units of insulin is eye-catching. The other thing's going to happen is your ears are going to be burning from everybody else saying, oh, sweet mother of God. You have to know it's right. And then you're going to follow with an infusion of 0.5 to 1 units per kilogram an hour. Okay, 35 unit per hour insulin infusion. All right? So titrate it to effect that it takes 15 to 60 minutes to start working. Don't get yourself in trouble. What's going to happen if you give me 7 units of insulin? There's a fair chance my blood sugar will go down. So make sure you're paying attention. Just check the blood sugar. Make sure there's a good glucose infusion rate throughout the time that this insulin infusion is up there. And check the blood sugar periodically. Because if you save the patient from the overdose and kill them from hypoglycemia, you're still going to get an M. Okay, it's still going to be a problem for you. Remember also that insulin moves potassium. It shifts potassium intracellularly, and so watch the potassium in these patients you're giving a ton of insulin to. What's another good idea? Another good idea, some lipids, right? So we're talking about not this kind of fat, which would be an awesome cheeseburger, but a 20% intralipid. This model looks like propofol, but it's not. All right, there's not enough lipid in propofol to make it work. You have to get from the pharmacy the 20% intralipid. And there's not amazing science about this. It's mostly case report science. But really, like 70% of this meeting is case reports and blog posts that we're passing off as facts. So it seems like a pretty good idea. So, and this is recognized as a second-line therapy for patients with calcium channel blocker and beta blocker poisoning. Okay, so it improves free fatty acid transport, indirect inotropin. It may just sequester the drug. So you're going to give them 1.5 cc's per kilogram over a minute, then give them a bolus and repeat it as needed. Again, this is a second-line therapy. The complications here are a little bit funny and related to the lipid load. So pancreatitis and respiratory distress syndrome. All right, you sort of die less from pancreatitis and respiratory distress syndrome than a calcium channel or beta blocker poisoning so bad that we're thinking about giving you lipids. But no, there's not enough science behind it to know what the actual complication rate is. Who in your training or in your practice up till today gave glucagon to patients who had beta blocker and calcium channel blocker? Everybody, right? I remember when I was in paramedic school, that was the most awesome thing in the world because it made no sense. We didn't actually understand any kind of things. It worked like $1 million. And everybody still knows that it does. The deal is, it's not a recommended therapy anymore. Okay? And that's because the adverse effect profile, what are the adverse effects of glucagon? The big one is everybody throws up, right? Who uses the most glucagon in the whole world? GI endoscopy to relax your esophagus. So almost everybody who gets a therapeutic loaded glucagon starts to throw up. The response, the heart rate, blood pressure response is very inconsistent, and it clearly doesn't work as well as an epinephrine infusion and insulin do. So it makes almost no sense to use that if you have the other armamentarium. Okay? So glucagon, although we love it, is no longer recommended. My last 1 minute here, I'm going to go fully into the evidence-free zone, and I'm going to talk about using methylene blue for refractory poisonings and hypotensive patients. And who's done that? Always hoping there's somebody, right? So who even knows what methylene blue is? Yeah, it's a dye for gram stains. If you're a super old intensive care unit nurse, like some of the people standing up front right now, you're used to using the color tube feeds. Okay, so it's also an anti-malarial drug, so I think Libby takes it all the time. It's used to synthesize and it's the treatment of choice for methemoglobinemia. Okay, so it's an excellent tox intervention for people who have methemoglobinemia. It also appears to work very well because it impairs the nitric oxide synthesis. And so it appears to be good for refractory vasodilatory shock. Refractory shock that's related to vasodilation. So actually it's the vasoplegic shock, where you have nothing else that can restore vasomotor tone. The methylene blue may make it work. The science for this is all in cardiac bypass, and the rest of it is case reports. But prevents smooth muscle relaxation through a couple of mechanisms, CGMP, nitric oxide related. It may improve performance in vasoplegic shock. All right, a great idea. It's cheap. The complications are not huge. Get it ordered before you try it the first time. Okay? So 1 to 2 milligrams per kilogram. The cardiac people will be semi-familiar with it. There's some interest for it in the shock literature, and the toxicologists are not opposed to it. Bolus 1 to 2 milligrams per kilogram, a little bit of infusion afterwards. You can titrate the dose if you like. Again, know that it's going to falsely lower oxygen saturation readings. Even though it cures methemoglobinemia, it can paradoxically cause methemoglobinemia, so watch out for that. It definitely, since it alters nitric oxide, definitely changes pulmonary mechanics, pulmonary blood flow and oxidation mechanics, so you can certainly get yourself in trouble there. And it's going to turn the patient's skin and urine blue. So, the headlines. Curious medical detective. Think toxicology when you can't explain what else is going on. All right, try to figure out what's up. Gastric lavage and charcoal are probably out. If you're thinking poisoning, think aspirin and Tylenol so that you don't miss something stupid. Something simple, so that you're not stupid and miss something simple. Consider sodium channel blockade in any patient who you believe is poisoned, has a QRS widening greater than 100, and an R3R. And you manage the sodium channel blockade poisoning with sodium. Remember, there's a lot of drugs that are sodium channel blockers. For the beta and calcium channel blockers, let them be together and do ACLS. All right. Epinephrine infusion is your friend. Atropine pacing may work. Norepinephrine infusion may be helpful. Then, first line therapy, insulin. High dose insulin is the first line therapy. Lipid rescue is the second line therapy, and glucagon is probably out. Methylene blue is a fun thing to think about. I have to get off the stage so that Dr. Galvagno can talk, and I'll be here a little bit today, all day tomorrow if you have questions or want to hand me your resume. So again, thanks for coming to Boston. Thanks for coming to this meeting, and I look forward to talking to you today and tomorrow. Thanks again.